Hello, and how are you? Welcome to a session on female genital mutilation related immediate physical complications and their management. This is part one. We shall do a second part to complete on the remaining bits. And my name is Winnie Barawa. To notify you, this is a series we are conducting on female genital mutilation, which is supported by the Girl Generation Kenya in coordination or in partnership with ACAF, which is Africa Coordinating Center for the Abandonment of FGM, and the University of Nairobi. If you're new on this channel focuses on lessons, lectures, and interviews pertaining healthcare. If this is something that is of interest to you, don't forget to subscribe. So keep with me as we move forward. So we are being explained that the risk of complications for women with FGM is more common in women who have undergone type 3 types of FGM, which is infibulation, compared to women who have undergone the other types, that is inclusive of type 1 and type 2 form of FGM. So if you've not watched about the types of FGM, we have a whole video in our playlist under gender and sexuality, and contains all the different types of FGM. You'll just be able to compare and understand what we mean by the fact that women with type 3 FGM are at a higher rate of getting more complications as compared to women including of the type 1 and 2. So let's focus and see what are the common immediate complications that women who have undergone FGM tend to experience. Among the immediate complications experienced include severe pain and tissue injury. There is hemorrhage, which can lead to development of hemorrhagic shock. There's also infections, and in cases where infections become severe, we develop septicemia or sepsis. Some women can get tetanus or gangrene. There's also genital tissue swelling, acute urinary retention, and in severe cases, some women can die or experience death. So in this case, death normally is prevalent in cases where there is hemorrhage, that is excess bleeding, in cases of neurologic shock, and also septicemia. So we explained that at the beginning, when you're handling the complications of female genital mutilation, in this case, specifically the immediate complications, it is good that you properly introduce yourself to the client. So introduce yourself to the patient and her family members, then ask the client about her presenting complaint. Like be tactfully, and ask and explore about any procedure that she had undergone. Let them describe in details how was it happening. Then the other bit is to reassure this lady that you will be comfortable dealing with her condition and that FGM is not really a barrier, but you can help them by ensuring that they will be able to access healthcare services, which will prevent further complications in their lives. So listen up to the girl, let the girl or the woman express their feeling and let them give you the information that they wish to share. And the other step is be patient. Remember, some of these clients are traumatized, they're in severe pain, they are bleeding, and the best they will wish to get from someone is an understanding and an empathetic spirit. So be careful and show empathy and concerns. Let her know that you can help her. Then the other bit is record. So the information that is being shared to you, it is good that you record the type and the complications that you're handling, but also you need to follow the right policy. So on the policy side, I have provided also the Kenyan policy when it comes to sexual violence, because FGM is another form of a kind of a sexual violence, which the Constitution of Kenya actually provides ways on how to handle it. So there's a whole video we've done on that, which caters for the Kenya Sexual Offense Act, which describes the different offenses and their punishment. But also I have done a video on how to handle clients who have undergone sexual violence. So you can learn more on how to manage this, but learn about the records and the documentation that are being done. Then the other bit is to assist and discuss. So after completing the clinical evaluation, you can now thank the woman, appreciate their cooperation, but ask and discuss with them the way forward and the best management in this regard to the client. Let's start with the first complication that is common in the immediate complications. So you have the severe injury or the severe pain, sorry, and severe injury. So when you're managing this case, number one, you need to scale up the pain, like understand how severe the pain case is. Are there any extent of tissue injuries? So assess the severity of the pain and check the extent of the tissue injury. Is there a grand case? Is it a case which is a mild? Is it a moderate? Or is it a severe case of pain and tissue injury? If you've established the severity, then you can begin intravenous fluid access. So if the person does not have an intravenous line, then you can establish one and secure the venous access. Then the first part is to give strong analgesics intravenously if it is possible, and then continue with the pain management until the client heals from their wound or from their injury accordingly. So other parts that you need to be careful with tissue injury is the risk of infections. So provide prophylactic broad spectrum parenteral antibiotics. This is to protect them from any form of infection that can be exposed into due to the status. So we are told to clean the site with antiseptic and advise the patient or her attendants to keep it clean and dry. Then treat the injury by way of stopping any form of bleeding and suture excessive tears or excessive injuries that the woman could have undergone. So surgical repair, it is expected or advised if there's extensive injury to the tissues. This is cases where there was excess use of crude weapons that ended up injuring the woman further, or neighboring tissues and organs were destroyed, so you need to learn how to perform the surgical repairs. Mostly this can be done bedside, or you can refer the woman for theater procedures. If there's any signs of hemorrhagic shock where the woman is excessively lost fluids or has excessively lost blood, then you can treat appropriately. And this could include even transfusion, that is blood transfusion, depending on the established hemoglobin levels or depending on the established blood volume that was lost. Then provide counseling. And in providing counseling, you want to calm down the woman and let her appreciate that actually in this state, they can be able to be treated and get well. So most of them are usually worried, wondering what will happen to them because sometimes they are not sure of the severity of the status and the outcome of their health. So provide counseling and if possible, refer them to the social services where they can be given extensive psychological management and referral system. Then the second complication is hemorrhage. So in hemorrhage, you are looking at status where there's excessive bleeding, which actually could be secondary to the procedure itself. And the bleeding can happen during or immediately following the FGM procedure. And in some cases, bleeding can also occur due to in cases of infections that could happen to women. So with hemorrhage, you need to be very quick and fast and sure. So you want to assess the woman quickly for the seriousness of the bleeding and the condition of the girl. You can check the vitals, check the pulse, check the respiration, check the blood pressure, check the SpO2s, establish if this woman has stable vitals. In cases where she's bleeding and the vitals are not stable, this is an indicator that the woman could be complicating. And as a healthcare worker, you need to intervene very fast. So you're told if the bleeding is serious and an intravenous line is available, then you need to be ensuring that it's well secured and then you try to initiate fluid replacement. However, you're told in the area where it is bleeding or the site where the bleeding is taking place, you need to apply pressure at the site to stop the bleeding. You can pack it, for instance, you can pack it with sterile gauzes or with a pad. If there's an active bleeder clamp, with a small artery, forceps, ligate, and cauterized. If the bleeding areas are so active and you wish to stop it completely, then you can apply some bleeder clamps, with nice forceps and ligations and cauterizations. Then, if really, really needed, don't stop giving fluids. Like replace the lost fluids and ensure the woman is stable vitally. This is the only way that you can be sure the bleeding has stopped and the bleeding has reduced. So keeping up with the hemorrhage again, there is further referrals or further interventions which include the basic emergency obstetric and newborn care, and also the comprehensive emergency and obstetric newborn care. These are guidelines that are provided to help us with management of hemorrhage cases among women who have undergone different maternal procedures. So in this case, you can apply the rules of airway, breathing, circulation, and so on, which basically helps us to ensure that the basics of vitals are kept at par and any complications are brought into the limelight and they can be managed. Then there's provision of counseling again, just like in the tissue injury. Counseling is very key because with counseling, you're sure that you can prevent any mental complications. You're able to reduce any forms of anxiety, and this lady can become cooperative for the management that you're going to give next. So educate about the lady in terms of antibiotic compliance, perineal wound care, effective management and monitoring of their own recovery. Having established good counseling, most of these mothers will be so good for you to, the women will be so cooperative to understand about the further management that can make them get well. So it's advised that you actually, educate on promotion of antibiotic compliance, advise more on perineal wound care, like you can talk about antibiotic application of the wound, hygiene and cleanliness, ensuring that it is free from infection, and you can even advise about seat pads to just basically keep them clean and neat without risking any further infections and sepsis. Then educate on menstrual hygiene, that is using products that are standards and they are being recommended for women who are in such a state. Then can follow up on the clients to monitor on progress, which will include monitoring of the perineal care, pain management, and psychological status. And then, of course, being a hemorrhage case, there's a lot of bleeding, there's a lot of blood that is being lost. So it's advised that you investigate for further causes of anemia and manage that status appropriately. So you don't want to make the patient lose a lot of blood. You don't want to risk development of anemia in the patient. And lastly is on hemorrhagic shock. So with hemorrhagic shock, this is an approach where you want to, number one, having been sure that there was no severe injuries for this woman, you want to also be sure before you reach here, you have eliminated any status of shock. And so the lady has been stabilized enough. Now, if that doesn't work, then you are worried about hemorrhagic shock. And this is a complication of hemorrhage or a complications of bleeding. So in this case, what are we gonna do? You can adopt Dr. ABC, where you want to rule out now, like airway, you want to rule out danger on airways, breathing, and circulation. So you want to apply the protocol of ABCs to just ensure that the lady is stable when it comes to airway access. She's stable in terms of breathing, and the circulation is also stable. So if she's having difficult breathing, you're advised to administer oxygen. If there's no intravenous line, then you can secure one and establish fluid replacement if there's a lot of fluid that has been lost. Then try to keep the client warm, because in hemorrhagic shock, most of the clients tend to suffer from hypothermia, that is low temperature levels. So in this case, you want to encourage warmth, which is very good for their metabolic status anyway. Then initiate blood transfusion if you have discovered that the HB levels are very low and you're worried you could take them into further hemorrhagic shock. So establish resuscitation equipment again, because you don't want the client to end up into unconscious status, which can force them to end up in ICU or intensive care units. So these are approaches that you can put in place as you're managing the bleeding client or the hemorrhagic client. So establish the ABCs, check on the fluids availability, provide proper temperatures, and then prepare for blood transfusion if there is need be, and then put the resuscitation set ready just in case. This is not like you will anticipate any, but put it ready just in case. So that marks the end of our first part when it comes to the immediate complications of FGM. So we'll go to the second part. So keep it as here with us. And again, if you've not subscribed, please do so. Share this in your platforms and then leave us a comment on areas you wish you've not understood and you would like us to explain it further for you. We are here. So thank you once more. See you in our next lesson.